Good evening, ladies and gentlemen, dear attendees from different countries in Europe, from Bulgaria, Cyprus, Croatia, Greece, Israel, Romania, Slovenia, and Croatia. We are happy to have you here. My name is Eugenia Papalexi. I'm the Medical Director in Business Area South. And on behalf of Lundbeck, I would like to warmly welcome you in this webinar, where we're going to discuss about ways to optimize treatment in major depressive disorders for our patients, and discuss a bit the dose relevance and the dose dependent effect of the antidepressants until now, the data that we have until now. Just a few logistics before giving the floor and introducing our main speaker today, Professor Andrea Fagiolini. I would like to just point out three things concerning logistics. First of all, the questions, you're going to have the option to have questions, to pose questions during the presentation of a professor. You can type the question in the text box in the chat. In case you are from Greece or from Bulgaria, you can write it in the local language and we will do the translation. Otherwise, it would be very nice to have it in English. This is one point of interaction and engagement. You know, it is really important, especially when we are in a digital environment. So the second point of interaction, of course, has to do with poll questions. You will see three voting questions during the presentation of Professor. And please vote so that we can share your clinical experience with your peers, with the other attendees. And last but not least, at the end of the presentation and after the Q&A session, we have an evaluation questionnaire where you can give us your feedback concerning the presentation and the whole event. Just a quick note here concerning the questions that you can pose and the polling of giving your own experience and vote. Please do not do that in full screen. You will have to escape, you will have to exit the full screen, because actually the question and the voting is underneath the video player. So that's it from the logistics point of view. I have the privilege, and I'm really glad to have Professor Fagiolini with us, Professor Andrea Fagiolini, to discuss in our webinar his clinical experience, but also the data concerning the dose relevant effect of antidepressants. Just a few words for Andrea Fagiolini. He is the Professor of Psychiatry and Chairman, Chief of Medical Sciences and Residency Training Director at the Department of Mental Health and Sensory Organs in the University of Siena in Italy. He received his medical degree in Pisa. He also did his residence training in Modena, Italy. Apart from that, and afterwards, he spent 10 years in Pittsburgh, in the medical school there in the US, where he served as an associate professor of psychiatry and medical director of the Bipolar Disorder Center and the Depression and Manic Depression Prevention Program. Of course, his research interests focus mainly on the pharmacological treatment of mood and psychotic disorders. And last but not least, apart from being a clinician, he also serves on the editorial board as a reviewer also for several psychiatric journals, being an author at the same time and co-author of over 400 books and peer-reviewed articles. So, Professor Fagiolini, the stage is yours. We're so happy to have you.
Thank you. Thank you very much. And thank you everyone for the opportunity to be here today to talk about strategies to optimize the treatment in major depressive disorder, and we will review the relationship between dose and response effect of antidepressants. These are my potential conflicts of interest. So when it comes to talking about personalizing treatment for depression, we have to keep in mind that depression is very heterogeneous. We may have two patients that have the same diagnosis of major depressive disorder that do not share one single symptom. So we have to keep in mind that we have several treatments for depression. And if you look in general at the efficacy of a medication or a psychotherapy for depression, you don't find huge differences in general. But when it comes to looking at differences in terms of efficacy for single symptoms of depression, there are actually differences between one antidepressant and another. And we will also see that there are differences between one dose and another for certain antidepressants. So we'll go and look at the treatment of depression in general, but we will also look at treatment of specific symptoms in depression. We know that when a patient is depressed, that person may experience emotional symptoms of depression, such as a sad mood, anxiety, guilt feeling, loss of interest, hopelessness. Also, cognitive symptoms are very frequent in depression, with problems with concentration, problems with memory, problems with executive functioning, and also physical symptoms like fatigue, sleep problems, changes in appetite, psychomotor agitation or retardation, and so on and so forth. These symptoms all lead to a decrease in functioning, but may be present differently in different individuals. One thing is a person with depression and insomnia. One thing is a person with depression and hypersomnia. One thing is a person with psychomotor agitation. One thing is a person with psychomotor retardation, and so on and so forth. So we need to make a diagnosis, major depressive disorder, major depressive episode, but then we need to go and look at the specific symptoms with which a patient presents. And some symptoms are targeted by the majority of antidepressants, but some other are quite specific for some antidepressants in terms of efficacy. We'll talk about all symptoms of depression, but we'll put particular attention on symptoms like emotional blunting, lack of motivation, anhedonia. These are symptoms where not all the antidepressants are the same, and where some antidepressants, for instance, SSRIs, SNRI, not only are unable to treat some of these symptoms, like, for instance, emotional blunting, but may give emotional blunting as a side effect. So in this case, for instance, SSRIs, we have done several studies showing that they are effective on depressed mood, they are effective on anxiety, but in terms of their efficacy on symptoms like emotional blunting, they're not very good. As a matter of fact, in addition to not treating emotional blunting, they may cause emotional blunting. They may make it worse. When we have to choose a medication, we also have to look at which particular monoamine or monoamines, for those that have effect on more than one, they may involve. So, for instance, we want to empower serotonin transmission if we want to target anxiety, if we want to target impulsivity, but we want to target dopamine transmission if we wanted to focus on drive, on motivation, on energy. Same thing for norepinephrine. Different antidepressants are working differently on different monoamines, and they have different mechanism of action. We know that SSRIs primarily work by inhibiting the reuptake of serotonin. We know that SNRI primarily work by inhibiting the reuptake of serotonin and norepinephrine. But we also know that we have a medication that is multifunctional, vortioxetine. This medication contains an SSRI, meaning that it inhibits the reuptake of serotonin, but in addition to inhibiting the reuptake of serotonin, also works specifically on specific receptor. So it increases serotonin by inhibiting its reuptake, but also it pushes on 5-HT1A receptor. That is the receptor that is linked to anti-anxiety and antidepressant properties, but also antagonizes important receptors such as 5-HT3 and 5-HT7, which are linked to the treatment of emotional blunting, which are linked to improving anhedonia, which are linked to improvement in cognitive function. And we'll look at these more in depth. We'll go and try to see which symptoms are predicting a response to one medication or to another. But more, in addition to this, we will also look at which symptoms require a dose or another dose of a medication, at least for some medications, such as vortioxetine. At this point, I have a question for you, just to share opinion about how we practice, what you would do based on your clinical practice. If you have a patient that is treated with an antidepressant, that patient does not respond to the initial treatment that you are providing. So you give an antidepressant, let's say paroxetine or citalopram. That patient doesn't respond to the dose you are giving to that medication. What do? Do you increase and optimize the dose? Do you quickly switch to another antidepressant? Do you do combination of two antidepressants or augmentation with a medication like lithium, like an atypical antipsychotic, like esketamine? Please just not stay on full screen, otherwise you won't be able to vote, and choose what you would do based on your clinical practice. They're all reasonable choices, so just choose the one you would do with your patients. Just 20 seconds, and then we'll comment together what you chose. Okay, I see that the majority of you, actually 88%, would increase or optimize the dose, which is reasonable, and we will see what the literature is telling us about this option. 7% would switch to another antidepressant. So 7%, if they don't see an improvement, let's say with 20 milligrams of paroxetine, they would switch to a different antidepressant. Another 7% would combine to a different antidepressant, would combine with another antidepressant. For instance, you treat a patient with paroxetine, that patient doesn't respond, you add a medication like bupropion, like mirtazapine, or another medication to paroxetine. We'll look at what the literature is saying. As I was mentioning, all these options are reasonable because increasing or optimizing the dose can be a good choice. In my experience, and we'll see what the research is showing, this is a very good option for patients that have a partial response. So if somebody shows a little improvement, at least, let's say 20, 30% improvement with 20 milligrams of paroxetine, it's reasonable going to 30 milligrams. But if you don't see any improvement at all with 20 milligrams of paroxetine, 50 milligrams of sertraline, 75 milligrams of venlafaxine, 20 milligrams of citalopram, it is unlikely we will see that increasing the dose will lead to response. So in this case, where you don't have partial response, it's very reasonable to switch to another antidepressant like somebody suggested. In some cases, we would combine with a second antidepressant or with another agent like lithium, like an antipsychotic, especially if this is not the first medication that the patient is failing. Let's take a quick look at how different doses work for some medication. So there are some medications where the efficacy with different doses is different than other medications. In other words, there are medications where even if you don't see a response to a certain dose, it's a good idea to increase the dose, because for those medications, and I'm referring primarily to vortioxetine, we will see what the data is saying, basically that if you don't see a response, or if you see a response that is not complete with 10 milligrams, there are reasons, pharmacodynamic reasons, why you should push the dose to 20 milligrams. Vortioxetine is one of the medications that work more powerfully if you increase the dose, both in partial responders and in non-responder to lower doses. There are instead other medications like citalopram, venlafaxine, sertraline, and so on and so forth that are unlikely to work if you increase the dose, if they have not worked at a lower dose. Let's look at the dose-response relationship of antidepressants for patients with major depressive disorder. First off, let's look at SSRIs or SNRI. We know that medications such as citalopram, fluoxetine, sertraline, paroxetine, venlafaxine, when they're used at the doses that we usually prescribe, occupy around 80% of the serotonin transporter. So let's say citalopram, you go from 20 to 40 milligrams, the occupancy of serotonin transporter remains around 80%. Fluoxetine, occupancy of the serotonin transporter remains around 80% when you go from 20 to 60 milligrams. Same thing when you go from 50 to 200 milligrams of sertraline, from 20 to 50 milligrams of paroxetine, or from 75 to 225 or even 300 of venlafaxine. In this case, increasing the dose does not change much the percentage of serotonin transporter that is occupied. What happens in terms of response and tolerability? Here you can see the results of a very nice study where they included studies about SSRIs involving citalopram, escitalopram, paroxetine, and sertraline. These medications were all converted to an equivalent dose of fluoxetine. So they just converted, for instance, sertraline, 200 milligrams of sertraline, equivalent to 60 milligrams of fluoxetine. Paroxetine, 50 milligrams of paroxetine, equivalent to 60 milligrams of fluoxetine, and so on and so forth. And then they looked at how increasing the dose of this medication, you would see an increase in response. As you can see in this picture on the left, the increase in the equivalent dose of fluoxetine is not leading to an increased likelihood of response. In other words, in fixed dose studies, in studies where you establish upfront that you try 50 milligrams of sertraline, 100 milligrams of sertraline, 200 milligrams of sertraline, you don't see unequivocally that the higher dose leads to higher response rate. Response rate to 50 milligrams of sertraline is equivalent to response rate to 200 milligrams of sertraline. The same is true for citalopram, escitalopram, and paroxetine. But if you look at the graph here in the middle, by increasing the dose, you dramatically increase side effect and dropout rates. So for these medications, basically SSRI, SNRIs, you can say that an increased dose is unlikely to lead, higher dose is unlikely to lead to higher response rate, whereas higher dose is correlated with a higher risk of side effects and dropouts. What we know is that when there is non-response, patients do not respond at all to medications, some medications, SSRI or SNRIs specifically, an increase in the dose is very unlikely to increase the likelihood that they will respond. So non-response, meaning not responding at all, it's unlikely to lead to response if you increase the dose. But as this study clearly shows, it increases the risk of side effect and the risk of dropouts. Let's look more in depth, more closely at venlafaxine. With venlafaxine, you see that when you go from 75 to 150 milligrams, you increase the likelihood of response to treatment. But when you go above 150 milligrams, you don't see any increase in the likelihood of response, but you see a clear increase in the likelihood of side effects and dropouts. For mirtazapine, it is even worse, because for mirtazapine, when you go above 30 milligrams, you see a decrease in the likelihood to achieve response. So not only don't you see an increase in response, but you see a decrease. And not surprisingly, as you increase the dose of mirtazapine, you see more side effects and a higher rate of dropouts. Let's now look at vortioxetine, which, as I was saying at the beginning, it's different from the other medications, different from SSRIs, different from SNRI. One of the differences come from the fact that vortioxetine is an inhibitor of reuptake of serotonin, has a good affinity for the transporter, but not extremely high affinity. That's why we need higher doses. Plus, it needs to work on all the other receptors that you see here, 5-HT1, A, 5-HT3, 5-HT7, and so on and so forth. By blocking 5-HT3 receptor and by blocking the serotonin transporter, if you use the appropriate dose of vortioxetine, you don't just increase serotonin. You do increase serotonin, but you also increase norepinephrine, dopamine, histamine and acetylcholine, and you remodulate the balance between GABAergic and glutamatergic system. Let's look at what this medication is doing on the serotonin transporter. We have seen earlier that blockage of 80% of the serotonin transporter is key to theoretical effect of SSRI, SNRI. You see here that the average blocker of the serotonin transporter for vortioxetine at 10 milligrams is 63%. So if you wanted to block 80% or more of the serotonin transporter, you need to go with 20 milligrams a day. That's why the majority of patients can benefit from a dose of 20 milligrams more than from a dose of 10 milligrams. So for this medication, the situation is different than the situation that I have described for SSRIs or SNRIs. Basically, with vortioxetine 5 milligrams, you see approximately 50% occupancy of the serotonin transporter. With 10 milligrams, about 65% occupancy. With 20 milligrams, you achieve the target of greater than 80% occupancy. Now, in terms of what you do in clinical practice, I have another question for you. If you see a patient that does not completely respond to vortioxetine at 10 milligrams, or if you expect that a patient is unlikely to respond to 10 milligrams and you think that 20 milligrams is the best dose, what do you usually do in your practice? When do you raise the dose from 10 to 20 milligrams? Do you do it after 1 week on 10 milligrams, after less than 1 month, less than 2 months, or more than 2 months? Please choose the option thinking to a patient on vortioxetine that is being treated with 10 milligrams. How long does it take before you increase the dose to 20 milligrams? Looking now at your responses, I can see now that the majority of you is now choosing, we are at 60% less than 1 month, and we have about 30% after 1 week, and then 5% less than 2 months, and 5% more than 2 months. So the difference, I see that the majority, 65% now versus 23%, chose option B or option 1. Again, they're all very reasonable. Option B, less than a month, includes any time between 1 week and a month, and that is probably chosen from those that want to see if 10 milligrams work, and then if it doesn't work, increase to 20 milligrams, which is very reasonable. Those people that increase after 1 week, and I am among those, I usually take 1 to 2 weeks before I increase, are those people that believe that the target dose should be 20 milligrams. So usually I don't even wait to see if 10 milligrams works unless it's an elderly patient. For elderly patients, I wait a little bit more on 10 milligrams. If necessary, I go to 20, but I prefer to wait before going to 20. But if the patient is an adult, usually after a week, 10 days, if the tolerability is good, as it happens for the majority of patients, I increase to 20 because I know that 20 milligrams is more likely to bring patients to response and even more likely to bring them to remission, meaning not only responding, not only improving by 50%, but going to a point where they don't have any symptom. And this is consistent with clinical trials. In clinical trials, you see that only 20 milligrams achieved a significant difference from placebo after just 2 weeks. And then you see at week 4, at week 6, at week 8, this is in fixed dose studies, 20 milligrams always led to greater improvement in the score in Montgomery-Åsberg Depression Rating Scale compared to other doses, 5, 10, and 15 milligrams of vortioxetine. So usually you see much better responses with 20 milligrams in general, overall score in Montgomery-Åsberg Depression Rating Scale, but you see the greater magnitude of response, not only in the general score of Montgomery-Åsberg Depression Rating Scale, but also in the scores of all the symptoms, basically all the symptoms or almost all the symptoms of the Montgomery-Åsberg Depression Rating Scale. So with 20 milligrams, you see more symptoms improving, or at least symptoms improving to a greater magnitude, to a greater extent. Here you can see another study observing the efficacy of vortioxetine on functioning, and again, the improvement in functioning is consistently greater with 20 milligrams compared to the other doses of vortioxetine. In terms of tolerability, is it true that for vortioxetine you see the same things that you see for other antidepressants, meaning that increasing the dose, you also increase the side effects and the likelihood of dropouts? No, that it is not. For vortioxetine, it's very interesting that if a patient tolerates 10 milligrams, that patient will tolerate without any problem also 20 milligrams. Of course, if you have a patient that is having some side effects with 5 milligrams, you see more side effects with 10 and you see more with 20 if you don't wait enough time for those side effects to subside. But if somebody is tolerating well 10 milligrams, that person will tolerate as well 20 milligrams, and you see much more power. See, the only side effects that are dose-dependent are nausea and vomiting. However, these side effects are dose-dependent, meaning that if they appear at low doses and you increase the dose before they subside, increasing the dose will make things worse. But if they don't appear, or if you increase the dose after they're subsided, they're not giving you any trouble. For the other side effect, you see pretty flat curve, meaning that with the increase in the dose, you don't see an increase in the side effect. What happened in flexible dose studies? Because the studies that we saw until now were fixed dose studies, meaning they knew upfront which dose each group of patients should receive. So we were having patients that were supposed to stay on 5 milligrams, patients on 10, patients on 15, patients on 20 milligrams. Decided up front that was the target dose. Each member of that group should achieve the specific target dose. How about flexible dose study? Flexible dose studies were studies where the investigators were able to increase the dose if the patient did not respond to a lower dose. You see that in the study evaluating the efficacy of vortioxetine on cognitive function, the mean dose was 16 milligrams. Study evaluating functioning, ability to work, mean dose 15.2 milligrams. In the study evaluating the efficacy in treatment-resistant depression of vortioxetine versus agomelatine, 64.7% of patients received 20 milligrams a day. So the higher dose was preferred in the majority of the patients participating in this study. Now, in your practice, again, based on your clinical practice, how many patients do you think will benefit from an increase in the dose of vortioxetine to 20 milligrams? So do you think about 20% of MDD patients, 20 to 40% of MDD patients, about half of MDD patients, more than 60% of MDD patients? So think about patients treated with vortioxetine. How many of them do you think should go to 20 milligrams in your practice? And I'm looking now at your answers. And I see that you tend to arrive, majority of you is going to like, actually it's now 35%, more than 60% of your patients. Another percentage similar, 33%, about half of the patient, 21 to 40, 28% to 21 to 40, and only 7% up to 20%. So actually, I see that we're practicing in a similar way, because the majority of my patients go straight to 20 milligrams, because I know that with 20 milligrams, even those that have responded will respond better, they will tolerate the medication better, and 20 milligrams is usually the target and standard dose, at least for adult patients. Let's quickly look at treatment of patients with comorbid depression and anxiety. It's very frequent comorbidity between depression and anxiety, and it is particularly frequent the comorbidity between depression and generalized anxiety disorder. There are very many patients with these two illnesses present together. And usually when you have a patient with depression and generalized anxiety disorder, in 1/3, you see that the two illnesses begin together. So they begin at the same time, major depressive disorder and generalized anxiety disorder. In 1/3 of these patients, the illness starts with depression and then generalized anxiety disorder arrives. In 1/3, it starts with anxiety and then depression arrives. But the two illnesses, as you can see in these slides, are very, very frequently present together. We recently studied vortioxetine in patients that were experiencing depression, full-blown depressive episode, and generalized anxiety disorder as a comorbid illness. In this study, vortioxetine showed to be very effective in treating depression. Here you can see the results at week 1, at week 4 in orange, and at week 8 in gray, dark gray. On the left, it's improvement in scores of depression. On the right, you see improvement in the scores of the Hamilton scale for anxiety. So vortioxetine was highly and significantly effective both for the treatment of depression and for the treatment of anxiety. The interesting thing, again, in this study is that 87% of patients received and maintained a dose of 20 milligrams. So almost 90% of patients arrived to 20 milligrams and stayed at 20 milligrams. So not only is vortioxetine highly effective in depression, especially at 20 milligrams, but at the same dose, it's also highly effective in comorbid generalized anxiety disorder. Lastly, I wanted to look at the efficacy on the 2-3 symptoms I was mentioning earlier: emotional blunting, anhedonia, and avolition, low motivation. The difference between emotional blunting and anhedonia is not huge, but there are some differences, because with anhedonia, you have inability to experience pleasure. So the patient doesn't do anything because he or she is unable to experience pleasure. It starts from inside the head, an inability to experience pleasure, and therefore I don't enjoy anything. Emotional blunting is different. Emotional blunting comes from the outside, meaning there is a positive stimuli, so something good happens, or negative stimuli, like something bad happens and I don't care. So something happens, either positive or negative, and I just don't care. I'm unable to react to external stimulation. It's like being anesthetized. It's like losing creativity. It's like losing the colors of life. I feel completely flat. I feel completely insensitive to anything that can happen outside. This is very unpleasant because it leads patients to discontinue in treatment. It's not pleasant to being completely anesthetized from the external environment. Let's look at the efficacy of vortioxetine for anhedonia and for emotional blunting. This is a nice study from the group from Toronto showing that when you treat patients with vortioxetine, not only do you see a clear improvement in the general score of Montgomery Asberg Depression Rating Scale, but you also see a clear improvement in the score in the scale measuring anhedonia. This SHAPS scale is a scale, Snaith-Hamilton Pleasure Scale, is a scale measuring the ability to experience pleasure, measuring anhedonia. And as you can see with vortioxetine from baseline to week 8, there is a decrease in the score in these SHAPS, which corresponds to an increase in the ability to experience pleasure. Not surprisingly, improving anhedonia leads to improvement in general functioning and in quality of life. Very interestingly, there is also a clear improvement in social functioning, which is linked to the improvement in anhedonia. These results are similar to the results that were found in another study, the study I was mentioning earlier, that is the study comparing vortioxetine to agomelatine. Again, with vortioxetine, you see significantly improved depressive symptoms, but also significantly improvement in anhedonia compared to agomelatine. Lastly, I wanted to show the results of this study where I had the pleasure of being principal investigator. This is a study that basically was born from clinical observation because what we saw was that many patients treated with SSRI, SNRIs, when they were recovering from depression, they were still experiencing emotional blunting. They were complaining, feeling flat, feeling insensitive to what was happening around them. And what we saw was that when we put these patients on vortioxetine, that improved. Patients were no longer saying, I feel anesthetized. I mean, we have a service for our students here in the medical school. Many students would go out of depression, but then they didn't want to study because they didn't care about building a future. They didn't care about the negative consequences. They didn't care about their parents complaining. They were just insensitive. They didn't care at all. And they were also unable to enjoy the good things that may happen to them if they were rewarded with something. We saw that when we switched these patients to vortioxetine, in many cases, the situation changed. So we decided to test this hypothesis in a multicenter study where patients with a partial or non-response to SSRI, SNRIs that were experiencing emotional blunting were switched to vortioxetine. We wanted to look if vortioxetine would improve emotional blunting along with the improvement of depression in these patients that were recruited on the basis of having emotional blunting. This hypothesis came also from pharmacodynamic observation because we know that SSRIs increase serotonin. Serotonin stimulates GABAergic interneurons, and the stimulation of GABAergic interneurons by serotonin leads to a decrease in dopamine, norepinephrine, and acetylcholine. So the decrease in dopamine especially, but also in norepinephrine, may be the cause of emotional blunting from SSRIs and SNRIs. What happens with vortioxetine is different because vortioxetine blocks the serotonin transporter, increases serotonin, but also blocks 5-HT3 receptor in GABAergic interneurons. This means that serotonin is no longer able to hit these interneurons. And so not only don't you see a decrease in dopamine, norepinephrine, and so on, but since 5-HT3 receptor in GABAergic interneurons are blocked, you see an increase in dopamine and norepinephrine with vortioxetine. And that's why this medication is so good in treating emotional blunting, in treating anhedonia, in improving motivation. And here what we saw in this study, in fact, these patients were switched to vortioxetine. After 1 week, there was already an improvement in the scale measuring emotional blunting. It's this Oxford Depression Questionnaire that measures basically emotional blunting. Now, this improvement in emotional blunting could be due to the fact that patients were switched from another medication to vortioxetine. So at this point, at week 1, we didn't know yet if it was the improvement was due to discontinuing the previous medication that was likely giving emotional blunting or was due to vortioxetine. But as you can see, at week 4, the improvement was much greater. And of course, at week 4, it was no longer attributable all to the discontinuation of the other medication. This was due to the new medication, and even more so at week 8, even further improvement in the score of emotional blunting. Very interestingly, at week 1, at week 4, at week 8, we saw the improvement in the total score in the emotional blunting questionnaire, but we also saw the improvement in each of the 5 domains of the questionnaire. Not surprisingly, but very nicely, we also saw a clear improvement in motivation, a clear improvement in energy. We also saw an improvement in everyday functioning, and this is consistent with a study that was specifically designed to study the evaluation, the efficacy of vortioxetine in improving everyday functioning. What we know is that even for functioning, and this again comes from a study comparing different doses of vortioxetine, higher doses, again, along the same line, are linked to higher likelihood of improving functioning. So in conclusion, depression is very prevalent. The World Health Organization, beginning in 2017, established that depression is the first cause of disability among all medical illnesses. It's very burdensome, it's very painful condition. We have several treatments for depression. We have patients improving on many of those treatments, but many times they have a partial response. They improve in some symptoms, but they don't improve in some other symptoms. What we know is that SSRIs, SNRIs are good for depressed mood, are good for anxiety, but are not so good for symptoms like emotional blunting, like anhedonia, like lack of motivation. And what we know is that when they don't work, increasing the dose is unlikely to improve the likelihood that they will work. However, there are medications, and especially there is vortioxetine, that is highly effective not only on depressed mood, not only on anxiety when it is comorbid to depression, but it is also highly effective on symptoms like emotional blunting, like cognitive symptoms, like anhedonia and reduced pleasure, reduced ability to experience pleasure, and so on and so forth. And what we know is that differently from many other medications, for vortioxetine, there is a linear increase of efficacy when you increase the dose up to 20 milligrams. So choosing the appropriate medications and choosing the appropriate dose is key to treatment success in patients with depression. Don't wait too long if you have somebody that is not responding to 10 milligrams of vortioxetine, because for many patients, the target dose, as all the studies basically have shown, is 20 milligrams, and 20 milligrams is able to work on the classical symptom of depression, but also on those symptoms where other medications are not so effective. Thank you very much for your attention.
Thank you very much, Professor, for a very detailed presentation with a lot of data, a lot of recent data, actually, from the last 2 years. There is a question. I mean, we will leave a bit of time for others to join and have more questions, but there is a question concerning what about doses above 20 milligram? Do we have any clinical experience with vortioxetine, which makes, I mean, it made me smile, the question, because I saw that you had also a very recent publication concerning the supratherapeutic doses for vortioxetine.
Yes, actually, we just published a study. It's published on Primary Care Companion of the Journal of Clinical Psychiatry, where we reported about patients that were not responding to 20 milligrams treatment-resistant depression, and we pushed the dose up to 60 milligrams. Vortioxetine is usually a very safe medication. It's safe from a cardiovascular standpoint. It's unlikely to give many side effects. Of course, it's an off-label treatment, so we have to be careful. But for a relatively large number of patients, we have treated resistant depression, especially when there are comorbid conditions like not only generalized anxiety disorder, but for instance, with relatively frequent use supratherapeutical dose for patients with comorbid obsessive compulsive disorder, but also with very treatment-resistant depression. We relatively frequent, when patients are resistant, push the dose to 30, 40, in some cases even to 50 or 60 milligrams. We have to be careful about serotonin syndrome because it becomes very strong serotonergic medication, but we haven't had any case of serotonin syndrome. Sometimes you see some increase in tremor, some increase in sweating, but usually they're not very significant. And if you see these symptoms, you can stop increasing the dose, but it's very unlikely. As I was saying earlier, there have been clear studies showing that if you increase the dose from 10 to 20 milligrams, it's unlikely that you see increase in side effects. In our experience, if a patient tolerates very well 20 milligrams and is a patient that is treatment resistant, we have in quite a lot of cases increased the dose to 30 or 40 milligrams. If you want to take a look at that paper, you're welcome to send me an email and I will share the data, or you can just check. It's Primary Care Companion of Journal of Clinical Psychiatry of this year, 2022. Thank you for the question.
Thank you. Thank you very much. Now there's another question concerning your clinical experience, and you showed a lot of data for the complete study, for the emotional blunting, the anhedonia. We saw the Toronto group discussing also about anhedonia and the effects of vortioxetine. From your clinical experience, how is this observed clinically and when? I mean, what kind of examples could you give from patients that I know that you're treating with vortioxetine, and just elaborate a bit on that?
Well, patients that are experiencing these symptoms are very prevalent. It's very easy to find somebody that is complaining inability to experience pleasure. You know, the lack of functioning in patients with major depressive disorder is very, very frequent. You see in almost 100% of patients. At the beginning, it's a symptom of depression. Since somebody is depressed, that person starts not going out, spending all day in bed, and so on and so forth. But then it also becomes not only just a consequences of depression, it becomes also a cause of depression. So since they don't go out, since they stop working, they stop going to school, they become even more depressed, even more not interested in things. So there are symptoms that are extremely important. And these symptoms of anhedonia, emotional blunting, and so on and so forth have a huge impact on functioning, have a huge impact on quality of life. So for these patients, in my experience, the treatment with vortioxetine can really change their life, and pretty quickly, actually. It works pretty quickly on these symptoms. Sometimes you see that even other antidepressants work on those symptoms, but it is usually less likely. SSRIs are very good for anxiety, again, for depressed mood, but for these symptoms, for cognitive symptoms, emotional blunting, anhedonia, for these symptoms, actually, in my experience, and honestly, vortioxetine is really the best, because the other antidepressants very often they don't work, and in some cases they're even making symptoms worse, like emotional blunting not only isn't treated by SSRIs, but sometimes is caused or worsened by SSRI. So we have to be careful to this symptom.
Thank you. Thank you very much. Now that we left a bit of time, there are more questions coming. So one of the attendees is asking, are there any differences in dosage in patients with other comorbidities, such as cardiac diseases or those that receive anticoagulants?
Well, one of the advantages of vortioxetine is that differently from basically all SSRIs, it does not inhibit nor does it activate the cytochrome P450. So it's relatively easy to combine vortioxetine with other medications because pharmacokinetic interactions are very, very unlikely. Differently, for instance, if you prescribe paroxetine, but also sertraline, fluoxetine, they are relatively strong inhibitor of the cytochrome P450-2D6, and you have to be careful about combining them with medications metabolized by the isoenzyme 2D6. The same thing for instance, fluvoxamine, that is a blocker of 1A2. Vortioxetine is primarily metabolized by 2D6, but is not an inhibitor of 2D6. So when you combine with other medications, the likelihood of interactions is very low. This is very important, for instance, for patients with cardiovascular disease or also with other diseases that are taking other medications. And also for patients with cardiovascular disease, vortioxetine is relatively safe in terms of extremely low likelihood to induce arrhythmias or to give weight gain, to give other problems that for these patients can be a huge burden. So it's relatively easy medication. It's actually one of the medications that we use the most in consultation liaison psychiatry inside the general hospital because of the lack of interactions, because of low likelihood to give weight gain, because of generally good tolerability.
Great, thank you. Now, in the area of combining treatments, there's a question, actually there are two questions more or less the same that overlap. Can we combine vortioxetine with other SSRIs, especially in doses around 20 milligrams when the patient is resistant? And also, what's your experience in combining vortioxetine with other antidepressants, for example, mirtazapine or trazodone?
Yes, this is a very good point. Thank you very much for these questions. Yes, for resistant patient, we always often do this combination. Again, we have to be careful in terms of avoiding the risk of serotonin syndrome. But if you go slowly with the dose, meaning you don't start 20 milligrams of vortioxetine from day one in a patient that is taking clomipramine or in a patient that is taking paroxetine or citalopram, you go slowly and then you slowly increase the dose, making sure that you don't see changes in blood pressure, you don't see sweating, you don't see tremor. It's very unlikely. We haven't had one single case of patients with a full-blown serotonin syndrome with diarrhea, these symptoms typically seen in serotonin syndrome. But my recommendation is when you add the vortioxetine, which is good because it doesn't have a pharmacokinetic interaction, maybe it's a good idea to add 5 milligrams. Then after 2-3 days, you go to 10 milligrams. Then you wait a week, 10 days, and then you can even go to 20 milligrams. We have regularly combined it with paroxetine, with fluoxetine, even with tricyclic in some very resistant patients with depression and obsessive compulsive disorder. So looking at the comorbid diagnosis, we tend to use much higher doses in patients with comorbid obsessive compulsive disorder. Those are patients that usually need and tolerate higher doses of this medication. But in treatment-resistant depression, it's a good medication to be combined to even other serotonergic medication, or even more so to medications with a different mechanism of action, for instance, with mirtazapine, especially for patients with sleep problem, or trazodone, again, for patients with sleep problems.
Great, thank you. And now there is a question concerning the use of vortioxetine in functional gastrointestinal pain, SSRIs are used very often for functional gastrointestinal pain. Is vortioxetine equally effective, and which dose would you suggest from your clinical experience?
Yes. In my experience, it is as effective because the serotonergic part is maintained. Plus, there is a noradrenergic part that may help fighting the part related to pain. So it's equally effective to the medications that are well known to work on those illnesses. And the dose is basically the same, but in those patients, since they may be very sensitive to the serotonin stimulation at the beginning, I recommend not going too fast. Usually, I quickly go to 20 milligrams. In these patients with general gastrointestinal disease, not only this one that you were mentioning, I tend to go more slowly up with the dose. So for these patients, I start with 5 milligrams and make sure tolerability is good. Then after 1 week, I go with 10 milligrams. I wait another week or two, then I go to 15, and then I go to 20. The strategy here is to go up with the dose very slowly to give the body the time to adjust to this serotonergic stimulation.
Great, thank you. And just maybe to give a bit of time, although we have reached our limit, the last question could be concerning the voting questions, the poll questions that we had during the presentation. You commented, of course, in parallel about your clinical experience, but based on your clinical experience and on the patients that you have tried, you have used vortioxetine, what kind of percentage, which percentage would you say that your patients are in the highest dose, in 20 milligram? And when do you, most often increase the dose as discussed?
Well, the majority of my patients, I would say 85% go straight to 20 milligrams. I don't even wait to see if they work at 10 milligrams, because I know that even if they respond with 10 milligrams, when I push the dose to 20, even if they were telling that they were feeling well, they come and they say, oh, I'm feeling even better. I was not realizing that there was still something that I was missing. So great majority, I would say 85% go to 20. There are some patients, however, especially late life patients of age older than 65, 70, 75, which sometimes arrive to 20 milligrams. But for those patients, I go more slowly because usually patients above 70, they have less proteins, and so the free fraction that reaches the brain is higher. They have a decreased flow in the liver. They metabolize the medication a little bit less. So again, the blood level is higher. So people of age 80, 85, but even 75, I usually wait at 10 milligrams, a little bit more before I increase to 20. But adult patients, the great majority go to 20 because it's well tolerated and it is more effective than 10 milligrams.
Thank you. Thank you so very much. Thank you for your interesting talk, for all the experience, the clinical experience that you shared with us. A big thanks to all the attendees for keeping us company, for all your questions and for all your interactions. Please try and give us your feedback in the evaluation questionnaire that we have and will appear now after the presentation. Again, thank you very much and have a nice night. Have a nice evening. Bye-bye.
Thank you. Goodbye from me as well. Thank you, everyone.